Okay, so welcome. Today we will be teaching OBG. We'll be teaching OBG today, and there are a few topics which I want to do, but for the time being, let's get started. Hmm. Just a second. Okay. So, like, okay. So the way I was thinking I'll teach is I'll do 10 pages in an hour, and if I do 10 pages in an hour, I'll be able to finish all of them within like by 7. So it's 7 a.m. now. I can finish it all by around 10. I can finish all of it, and I can just relax the remaining time, I feel. So yeah, okay. Let's talk about physiology of ovulation. So oogenesis, development of mature ovum. Ovulation, release of sperm at a secondary oocyte from ovary following rupture of Graafian follicle. So primitive germ cell originates from yolk sac at third week of gestation, migrates to developing gonadal ridge at fourth week, and oogenesis begins in ovary at 6 to 8 weeks of gestation. 20th week, maximum number of oogonia are present in the ovary. At birth, mitotic division stops. All oogonia are replaced by primary oocyte, which is 2 million. Then primary oocyte in ovary of newborn are arrested in diplotin stage, and primary oocyte remain arrested in a phase called as dactyl stage till puberty. So diplotin phase in newborn, and dictylate stage till puberty. So gets surrounded by follicle forming primordial follicle. At puberty, number is further decreased to this number. At puberty, due to mid-cycle pre-ovulatory surge, meiosis is resumed prior to ovulation. First polar body is released just prior to ovulation. Second division starts immediately after it, and it is arrested in metaphase. At the time of fertilization, second division is completed. There is release of oocyte and second polar body. Yeah. Causes endocrinal. There is LH surge, sustained peak level of estrogen for 24 to 36 hours in late follicular phase. It will be sustained. 20 to 34 hours in late follicular phase. LH surge. The ovulation occurs 16 to 24 hours after LH surge. FSH rise. Pre-ovulatory rise of progesterone facilitates the positive feedback of estrogen, induces FSH surge, and it leads to increase in plasminogen activator. Plasminogen and plasmin helps in lysis of wall of the follicle. Sustained peak of estrogen for a few hours. Okay. This is ovulation. Begins at 6 to 8 weeks of gestation, 6 to 7 billion. Stretching factor is there, which is increased prostaglandin secretion, contraction of micro muscles in the theca externa and ovarian stroma. This is stretching factor. Effect of ovulation: follicle is changed into corpus luteum, ovum is picked up, into fallopian tube and undergoes either degeneration or further maturation if fertilization occurs. Menstruation is unrelated with ovulation. Anovulatory menstruation is seen in adolescents following childbirth and in women approaching menopause. So, primordial germ cell will enter the gonad of female and differentiate into oovonium, and mitosis will occur and the primary oocyte will be formed. They enter first meiotic division and arrest in diploidine. First meiotic division is completed after puberty prior to ovulation, releasing secondary oocyte, which is 22 plus X, and first polar body. Then secondary meiotic division begins and it is arrested in metaphase. Second meiotic division completed only at the time of fertilization. So ovum is formed and the second polar body is formed. Then placenta and membranes. Amniotic fluid index is used to assess amniotic fluid volume. Uterus divided into 4 quadrants. Measure largest vertical pocket of liquor in each of the 4 quadrants. Sum of the 4 measurements is the AFI. Normal it is 5 to 25. Less than 5 is oligohydramnous. More than 25 is polyhydramnous. Then you have D, single deepest pocket. Depth of a single cord free pocket of amniotic fluid. Normal is 2 to 8. Less than 2 is oligohydramnous. More than 8 polyhydramnous. Okay. Okay, so transport of substances, placenta function. Yeah, transport of substances, endocrinal, barrier, and immunological. So in transport of substances, respiratory, oxygen supply to fetus is this much, achieved by this much. Cord blood flow will be there. And excretory, you have urea, uric acid, and creatine excreted into maternal blood by simple diffusion. Nutrition, you have to give glucose, lipids, amino acids, water and electrolytes, and micronutrients. Then hormones, you have insulin, adrenal steroids, thyroid, HCG, and parathormone. Parathormone nor calcitonin it doesn't cross the placenta. Then the enzymatic function, you have diamine oxidase, oxytocinase, and phospholipase. Diamine oxidase is inactive circulatory pressure amines. Oxytocinase is neutralizes the oxytocin. Phospholipase A2 synthesizes arachidonic acid. Barrier is against noxious agent circulating in the maternal blood. Molecular weight more than 400 daltons. Exceptions are antibody, antigen, drugs, and torch infection. Immunologically, you have fetus and placenta contains parentally determined foreign antigens. No evidence of graft rejection is there. Placenta probably offers immunological protection against rejection. Mechanism, you have immunosuppressive effect of placenta on hormone SP1, EPF, PPA, and HCG. You have villus trophoblast, do not express HLA class 1 or 2 molecules. You have extravillus trophoblast, which only express HLA class 1 molecules and no HLA class 2 molecules. Then you have cinctio trophoblast, which has TLX antigen blocking antibodies produced by maternal immunity against TLX antigen, protects the fetus from rejection. Then fetus circulation is 3 in utero shunts exist within the fetus. You have ductus venosus, you have foramen ovale, and you have ductus arteriosus. Ductus venosus shunts blood from umbilical vein to inferior vena cava. Foramen ovale shunts blood from right to left atrium, and ductus arteriosus shunts blood from pulmonary artery to descending aorta. So source of oxygenated blood is placenta. So umbilical vein, left branch of portal vein is umbilical vein will go to left branch of portal vein, which will go to ductus venosus, which will go to inferior vena cava. Poor oxygen poor blood in superior vena cava will go to right atrium, will go to right ventricle, then pulmonary trunk, ductus arteriosus and aorta. Oxygen rich blood in inferior vena cava will go to right atrium, directed by IVC valve into foramen ovale. It will go to left atrium and it will go to aorta. And oxygen rich blood gets pumped via carotid and subclavian artery to upper body. Descending aorta has blood from ductus. Descending aorta has blood from ductus arteriosus, which is moderately saturated. Just go to umbilical artery and then to placenta. So physiological changes during pregnancy. Inspiratory reserve volume will decrease. Deepest breath in possible. Breath at rest will increase. Deepest breath out it will be remaining the same, and residual volume will decrease. I guess this is an easy way to remember. So plasma protein. Total plasma protein increases from 180 to 230 grams. Plasma protein concentration will decrease from 7.68 7 to 6 gram. Total protein will increase. Globulin will increase. Protein concentration, plasma protein concentration will decrease. Albumin will decrease. So albumin globulin ratio in pregnancy is 1:1, but in non-pregnant it is 17:1. 17:1 will become 1:1. Globulin will increase, albumin will decrease. Okay. In respiratory system, this much is enough. This much is enough for respiratory system. Minute oxygen intake and oxygen demand you can increase. Okay, it will be decrease in functional residual capacity, expiratory reserve volume. Inspiratory reserve volume will not be affected. There given inspiratory reserve volume will be decreased. I don't know what they want. I mean, volume of lung same. Volume lung volume, how much ever lung volume will be there, it will be the same. Tidal volume will increase. Respiratory rate will be same. Vital capacity will be same. Maximum inspiratory minus maximum expiratory will be the same. Is it? I forget what vital capacity is. Residual capacity will be decreased. Residual volume will decrease. Expiratory volume also will decrease. Residual volume will decrease. Total lung capacity will also decrease. How is vital capacity? Respiratory system is somewhat difficult. Yeah, let's just do this. Read from, how do you say? Okay, so renal system, you can find that renal blood flow will be increased, GFR will be increased, creatine clearance will be increased, and glucoseuria will be there. Plasma osmolarity will be decreased. Serum creatine, uric acid, potassium chloride will be decreased. GFR increases. GFR causes reduction in creatine, blood urea nitrogen, and uric acid levels in moderate maternal plasma. Elongation, kinking, and outward displacement of ureters can be seen. Frequency of micturition increases in T1 and T3, which is T1 is resting of osmoregulators. T3 is because of pressure on bladder as the presenting part descends down the pelvis. Renal system, there is dilatation of ureter, renal pelvis, and calyces. Renal plasma flow will increase by 50 to 70%. Maximum it will increase by 16 cuffs. 16 weeks. Maximum it will be by 16 weeks. Kidney will be enlarged in length by 1 centimeter. Hematological system. So, yeah, hematological system is one of the main questions they can ask. There is increase in vascularity of two uterus. Increase in blood volume is progressive and it is inconsistent. However, the disproportional increase in plasma and RBC volume produces a state of hemodilution. So there is a state of hemodilution because there is disproportionate increase in plasma and RBC volume. So plasma volume will increase a lot, but RBC volume will not increase. Advantages: protects the mother against loss during delivery. It diminishes blood viscosity, ensuring optimal gas exchange, and protects the woman against supine or erect position. So hematological system, there is increase of blood volume, 40 to 50% increase from 6th week, maximum in 30 to 34 weeks. Plasma volume will be 50% increase from 6th week, maximum at 30th week. Increase is greater in multiple pregnancy and multigravital large baby. Then there is increase in ESR, MCHC, mean corpuscular hemoglobin concentration, oxygen carrying capacity, because there is increase to extent of 20 to 30%. Total increase in volume is 350 ml liter percent. 2% increase in reticulocyte count. Erythrocyte level is poison. Clotting factors except 11 and 13 will be increased. Fibrinogen level will be increased. Neutrophilic leukocytosis can be seen. Bleeding and clotting time will remain unaffected in pregnancy. So there is decrease of hematocrit, packed cell volume, viscosity of blood, hemoglobin concentration, because there is increase in plasma volume, clotting factors 11 and 13, and platelet count. Benign gestational thrombocytopenia, there is decrease of platelet count. Okay, cardiovascular system, there is increase of heart rate, stroke volume, cardiac output. Carbon dioxide will increase by 40% during pregnancy, 80% immediately postpartum. Maximum risk of failure, cardiac failure in pregnancy is seen immediately postpartum, is more than intrapartum, is more than 28 to 32 weeks of gestation. There is decrease of peripheral vascular resistance due to prostaglandin. Then there is decrease in diastolic BP and systolic BP. Decrease in diastolic is more than systolic BP. Mean arterial pressure will also be decreased, and arteriovenous oxygen gradient will also be decreased. So clinical features, changes will be occurring during changes which occur during pregnancy. Heart rate increases. Apex beat shifts to 4th intercostal space, a little bit lateral. S1 splitting will be there. S2 will be normal. S3 will be loud and easily auscultated. Murmurs grade 2 systolic ejection murmur may occur due to expanded intravascular volume. Continuous hissing sound. Hissing murmur will be there. Over tricuspid area. Mammary murmur. So echo will find increased left atrial and ventricular diameters. ECG left axis deviation will be there. Chest X-ray straightening of left heart border. Then weight gain during pregnancy significance. Rapid gain in weight more than this value per week or more than 2 kg per month is an early manifestation of preeclampsia. Stationary or falling weight suggests IUG or intrauterine death of fetus. This is stationary or falling weight. Obese women increase risk of complications in pregnancy, labor, prepurum. Obese women BMI more than 30 not gain more than 7 kgs. Underweight women BMI less than 13 may allowed to gain up to 18 kgs. Ideal weight gain during pregnancy depends upon pre-pregnancy BMI. Total weight gain during course of significant pregnancy for healthy women is 11 kgs. Gestational tract changes in pregnancy, vagina, increased vascularity and hyperemia, bluish hue called Chadwick sign or Jacquemeyer sign. Increase in dodolin bacteria or bacilli, converts glycogen into lactic acid, decreases vaginal pH. Acidic pH inhibits the growth of a pathogenic bacteria. Histopathology, you have navicular cells can be seen. Uterus, you have non-pregnant woman is 70 kg and 7.5 centimeter. Pregnant uterus is 110 grams and 35 centimeters. Changes, you have hypertrophy and stretching. Hypertrophy, hyperplasia, estrogen, progesterone, stretching. Arrangement of muscle fibers, you have outer longitudinal, middle spiral and inner circular. Outer longitudinal, middle spiral, figure of 8 pattern, contraction acting as a living ligature, and inner circular. Position, you have non-pregnant and pregnant. In non-pregnant, it is anteverted and anti-flexed. Pregnant, it is dextro-rotated uterus due to rectosigmoid in the left quadrant. Cervix is levo-rotated. Baxter Hicks contraction is second trimester contraction, non-rhythmic, painless contractions. They do not lead to cervix dilatation. Then you have Ferguson's reflex, which is during labor, pressure on cervix stimulates uterine contractions. Cervix, you have Godel's sign and secretions. Godel's signs is softening of cervix. Secretions, you have copious and tenacious physiological leukorrhea due to progesterone. Breast changes in pregnancy, there is increased size of breast, marked hypertrophy and proliferation of ducts and alveoli will be there. So estrogen will be there. Changes are more evident in primigavida, and estrogen and progesterone will be there. Hypertrophy of connective tissue stroma will be there. Vascularity is increased. Appearance of bluish veins under the skin. Axillary tail becomes enlarged and painful. Nipple becomes larger, erectile and deeply pigmented. Montgomery tubercles, hypertrophied sebaceous gland in areola is appearing. Secondary areola, you have outer zone of less marked and regular pigmentation area around the areola. Appears in second trimester. Thick and yellowish colostrum can be squeezed out of the breast at 12th week. Then you have supine hypotension syndrome or postural hypotension or Meniere's syndrome. So, late pregnancy, gravid uterus, compression effect on inferior vena cava, patient is in supine position. Results in opening up of collateral circulation, paravertebral and iliacus vein. 10% of the cases, collateral circulation fails to open up, venous return of heart is compromised, hypotension will occur, tachycardia will occur, and syncope will occur. There is decreased maternal cardiac output, decreased fetal flow, and respiratory distress. Then normal blood pressure is quickly restored by turning patient to the lateral position. Augmentation of venous return, contracted pelvis prevents this manifestation from developing during labor. So venous return you have to do, contraction prevents this manifestation. HCG produced by placental syncytotrophoblast. Appears in maternal bed 10 days after fertilization, peaks at 9 to 10 weeks, plateau level at 20 to 22 weeks. Chemical structure is glycoprotein with two subunits. You have alpha subunit and beta subunit. Alpha is alpha subunit similar to LH, FSH and TSH. Beta subunit specific for pregnancy. Functions of HCG, you have maintain the corpus luteum, production of progesterone until placenta takes over the function. regulate steroid biosynthesis in placental fetal adrenal gland, stimulate testosterone production in fetal male testes. High HCG is seen in twin pregnancy, hydrated mole, and choriocarcinoma or embryocarcinoma. Low HCG is seen in ectopic pregnancy, threatened abortion, and missed abortion. Diagnosis of pregnancy: first trimester, increased urinary frequency, amenorrhea, morning sickness, breast discomfort, and fatigue. So signs: you have Jacobius or Chadwick sign, dusky hue, vestibule, anterior vaginal wall due to local venous congestion is there. It is seen in 8th week of pregnancy and in fibroids. Osiander sign is increased pulsation through the lateral fornices, 8th week of pregnancy. Godel sign is softening of the cervix, 6th week of pregnancy. Palmer sign is regular and rhythmic uterine contraction on bimanual examination, 6th week of pregnancy. Agas sign is bimanual examination, abdominal and vaginal fingers seem to be opposed below the body of the uterus, occurs because of softening of isthmus, 6th to 10th week of pregnancy. Calculation of expected date of delivery, EDD. So fruitful 266 days to be added from that date. Needle's formula is 9 months 7 days of the first date of last cycle. Okay, count back 3 calendar months, then add 7 days. That also can be done. Then IVF pregnancy, date of LMP is 14 days prior to the date of embryo transfer. Okay, date of quickening you can see, adding 22 weeks in primigravida, 28 weeks in multipara to the date of quickening. Previous records, if it's there, clinical. Oh wait, no. What is this? Yeah, previous records, size of uterus prior to 22 weeks more precisely corresponds with period of amenorrhea. Palpation of fetal parts, size of uterus prior to 12 weeks, auscultation of fetal heart rate at 18 to 20 weeks, ordinary stethoscope, and Doppler principle 10th week. Investigation records, you have ultrasound, record of positive pregnancy test, you have ultrasonographic and gestational sac at 5 weeks. Measurement of crown rump length, CLR is plus 6.5 is weeks of pregnancy. 7 to 8 weeks is 10 mm and 8 to 10 weeks is 34 mm. Then okay, objective signs, you have height of the uterus, lightening, labor is likely to commence within 3 weeks of lightening. Size of fetus, change in uterine shape, volume. Investigation, sonography, first trimester, crown rump length, second trimester, biparatal diameter, head circumference, fetal femur length measurements. X-ray, appearance of falsification center in tibia is 38 weeks, lower end of tibia is 36 weeks. Quickening, feeling of life, perception of active fetal movements, felt at 18 weeks, 2 weeks earlier in multipara. Quickening is felt at 18 weeks in primipara, 16 weeks in multipara. Appearance is useful to calculate the expected date. Then we have fetus in utero, fetal orientation. So lie is orientation of long axis of fetus to long axis of uterus. Longitudinal is fetus and mother in the same vertical axis. Transverse, fetus at right angle to the mother. Oblique, fetus at 45 degree to the mother. Longitudinal, transverse. Okay. Presentation, part overlying the pelvic inlet. Cephalic is head. Breech is sweet or buttocks. Frank is thighs flexed, legs extended. Complete is thighs and legs flexed. Footing is thighs and knees extended. Compound is more than one anatomical part, head and upper extremity. Shoulder. Then position, it is relationship of a definitive presenting part to the maternal bony pelvis. So occiput if there is a flex state, cephalic presentation, sacrum with a breech presentation, medium which is chin with a extended head face presentation. So this is the positions, and anterior frontal nail you have to remember, posterior frontal nail you need to remember, occiput you need to remember, and yeah, fine. Attitude is degree of extension flexion of fetal head with cephalic presentation. So vertex is head is maximally flexed, military is head is partially flexed, brow is partially extended, face is maximally extended. Station, it is the degree of descent of presenting part through the birth canal, centimeters above or below the mother's ischial spine. Station of fetal descent. Pelvic grip or leopard maneuver is you have okay, I am going to stop this actually all these are really easy. This one is very important. Okay, I'll continue after taking a break for some time. Okay, so yeah.